going back to the movements that are occurring in this region, because remember, that's going to be the key. What's normal? When we rotate our head to the right, what was the first thing I want you to feel? The translation of the atlas. The translation of the atlas is created by the dens via C2 tilting in the opposite direction. Literally pushes the C1 to the side. That's how we get the translation. It's not muscular. That's a simple mechanical process. By the age of 30, especially if we've been involved in sports when we were younger, the craniovertebral joints begin to show signs of degeneration, deterioration. So by the time we're in our 40s and 50s, it's quite common to see degenerative changes on a CT scan. Imagine that, and you're behind the wheel, you're looking up in the mirror and you get hit. So your head gets whipped back into rotation and extension. And this is forced here, not a normal movement, an abnormal forceful movement. It's quite likely that the atlas could sublux from translating too far. The ligaments will limit the amount of translation, so it's not like it's going to cause any problems with the arteries. But it will be enough to cause significant changes in movement. The biggest loss we see is side bending. So for example, I've rotated to the right, the atlas is translated excessively to the left and got stuck. I'm going to see a significant loss of left rotation, but a total loss of right side bending. It won't even be able to initiate the movement of the head. And the first time that Cliff and I ran into one of these, it was working with that orthopedic surgeon, and he asked us to come and look at this patient because he'd had a fracture of C7 from a motor vehicle accident. And he said the fracture's healed great, but this person has an incredible stiffness into left rotation and he has no right side bending. So we went to see him, asked to look at his movement, and we're looking at him, we were quite puzzled. And then the patient suddenly went, no, I can't do this, but I can do this. Going, what's that? He couldn't initiate side bending from above, but he could initiate side bending from below. So we began to realize what must be at fault. So we obviously tested his atlanto-occipital joint, his atlanto-axial joint, and sure enough, this is where we found our very first subluxation. Not that that was the first one that's ever occurred, it's the first one that we'd ever registered as seeing. And then it was looking at it going, okay, how are we going to treat this? And like any subluxation, the obvious answer was going to be distraction. Can we release that impingement, even though it's milliseconds, to enable it to go back to its neutral position? So distraction manipulation in both the AO and AA joints is really designed for injuries that occur to a degenerative craniovertebral region. That same deterioration can give us problems in the atlanto-axial joint. There is a classic injury that I mention in the book, which is caused from a patient slipping and hitting the back of their head on something. Normally, the typical thing is somebody going down steps or stairs, slipping on ice, bang, and hitting the back of the head. In a degenerative segment, the atlas can slip forwards. It's only millisecond, but it's enough to push it off the peak of the C2, the male on male surfaces. So now it can't go anywhere, because normally when you rotate your head, it drops down. They can't drop down in opposite directions because they're both stuck in the front. And the alarming thing is that these people come in complaining of tingling in their hands and feet, especially when they're doing things like writing, sewing, anything where their head is kept forward for a long time. When we very cautiously look at flexion, we notice that we don't get that same sharp burst of response. We can't turn it on and off. It takes a while for that quadrilateral paresthesia to come on. So that's, in a way, a good sign. But the disturbing sign is, why is this happening anyway? We're getting quadrilateral paresthesia with flexion. Something is wrong in the neck. So obviously the first thing you have to do is get a thorough scan or an MRI of the craniovertebral region in flexion and extension. Now remember, flexion and extension is different from rotation. With flexion and extension, there is no gliding. Not in the lateral joints, but in the medial or central joint between the dens and the anterior arch of the atlas, there is gliding. And that joint is designed, using the transverse ligament at the back, it's designed to slide down and up on the dens. And the skidding of the lateral condyles enables that to happen. So we actually see, if we x-ray from the side, we'll actually see the arch of the atlas tilting like this. And the space between the atlas and the axis increases on flexion. We anticipate that. And it's about 7 degrees on average. And the upper limit for that is 11. So somewhere between 7 and 11 degrees is considered within normal limits. Anything beyond that is considered to be pathologically hypermobile. But what they're looking at, more than that, is what's happening at the front. Thanks to the transverse ligament, the only way that anterior arch can move is along that slightly arcuate path. When you look at the models that we use, it looks flat. Well, it's not flat in life. There's a slight curve in the cartilaginous anterior part on the dens, and it slides around that. But there's no loss of contact. We can see a tilt, very small tilt like this. But the base, the distance between the base remains 0. It's in contact. So what the radiologists are looking for is a disruption in what's called the rule of thirds. If we look at the spinal canal at this level, the dens and the cord are about the same size. And the space between the cord and the dens and the posterior arch and the cord is the same size as the cord. So we've got the space, the same size as the cord, which is the same size as the dens. So they call that the rule of 3, or the rule of thirds. And what they're looking for is a disruption between the space, where, thanks to the atlas slipping forwards, the space behind the cord is decreased and the space in front is increased. As the cord comes forwards and pushes up against the dens the space between the dens and the anterior arch is increased. And there should be no space at all. So that's why it's important to understand the huge difference between rotation, where we've got a gliding movement, and the spinning that occurs with flexion and extension. Helps you to interpret whose tests are coming through. Also helps to explain the sharp Purser test. Sharp Purser test was designed because it is not uncommon for rheumatoid arthritics to have degeneration of the transverse ligament. So on flexion, we can get that drift. So the cord is brought forwards up against the dens. Then we simply fix C2, push the forehead back, and we get relief of the quadrilateral paresthesia. Again, is why we need to understand what's going on in this region if we're going to fully understand what happens to it. But also, when we come to treat it, what are our parameters? Where can we go and still be safe?
Well, is it prudent to ask for flexion extension X-rays then, if we want to check and ask for flexion extension X-rays?
Yes. You have to be a bit politically correct here, because people ask for flexion extension views or movement X-rays, and the radiologist can get a bit upset, because the correct term is positional X-rays in flexion and extension. And it's definitely acceptable and prudent to request that, because you're the one that has probably come up with the first sign that there's something wrong in this region. So because of this strange movement in the atlas, sometimes that limitation that we pick up in, oh, the right condyle can't flex or the left condyle can't extend, it could still be the disruption in the neutral position of the atlas. So many times the most advantageous technique for the atlanto-occipital joint is in fact distraction, and it will certainly be the safest one to try, as long as you stick to the rules and do not allow any significant rotation or extension to occur in your setup. So the technique is done in neutral. To avoid side bending of the head, this has to be a bilateral technique. It's not unilateral, bilateral. That way we avoid bringing in any other movement. And it was interesting, somebody also I'm hoping to get on the Aspire webinar is Stan Paris. And I met him in San Diego. It's a fun guy, I've always enjoyed his company. And I presented the paper on ligamentous testing of the craniovertebral joint. And then I started to explain some of the techniques we were going to use in the manipulation. And he came up to me at one of the intervals and said, "Earl, I've never met anybody so obsessed with safety." And I took that as quite a compliment. I said, yes, that, because his program in California, they had dropped manipulation, period. They didn't teach it. They brought us, Dave Lamb especially, to teach the manipulation part, because nobody felt that confident about the manipulation. And I said to him, you know, Stan, I feel really comfortable manipulating the neck, because I am obsessed with safety. And I don't think you can be too obsessive about that. So you've all had your ligaments tested, and hopefully there's been no adverse incidences since then. Or if there has, then we need to know it so we can check it. Have you had your ligaments tested recently? Okay, well, I can do you because takes only a minute.
Oh, that's you. Test.
Okay, I'll retest. And that's what I said. If you do it properly, smoothly, it flows. You're looking for obvious stuff. Like, this isn't subtle. Patients, when you say to them, tell me if you feel anything other than pressure or pain, well, even though you say that, as soon as you do something and they get pressure or pain, they're going to say, oh, that hurts. So you say, okay. You're not ignoring it, you're tabulating it, but it's not relevant for these tests. We're looking for obvious adverse responses. I remember way back when I was a very young therapist. I'd only just emigrated to Canada, so I'd been qualified, what would that be? I'd been qualified 2 years. And I was feeling a neck. I'd done no manual therapy at that time. And I was doing gentle traction to try and relieve this woman's pain. And she said, that's weird. I went, what? She said, every time you pull my neck, I get this tingling right across my lips like that. And it's almost, I want to scratch it. Oh, that's interesting. And carried on. I realised it's the classic sign of a basilar artery dysfunction. I didn't know back then. But also, I wasn't manipulating. But it's that kind of symptom we're looking for, something that's so obviously not right. I know you've even done this traction on other patients with alar ligament dysfunction, and they've got tingling in the pelvis. And it's like, okay, where does that come from? It's like, I don't know, and I don't care. There's something going wrong. Okay, let's not make this too subtle. It's a gross test.
Visit us at ASPIREOMT.com.